Hello, my name is Dr. Roger Henderson, and I'm a GP in South West Scotland, and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those of us working in primary care. Now, you can find us on all major podcast platforms, including Apple Podcasts, Spotify, and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you're liking what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GP Notebook for more information about new podcast episodes and study groups, and you can find me on there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now, we love it when you get in touch with us, and this week a GP regular listener has asked whether we would do something on rheumatoid arthritis. And although this is a huge topic, and you can have conferences that last several days simply on rheumatoid, then I thought it might be sensible just to do a quick overview as a refresher for all of us, just to remind ourselves about what we should be doing to not only diagnose our patients with rheumatoid, but also to give them the optimal management. So to start at the beginning, then obviously rheumatoid is basically a common autoimmune disease that's chronic and inflammatory. And as we all know, it's characterized by joint inflammation and destruction. But what is less commonly known is it is the most common inflammatory arthritis seen by healthcare professionals, and it affects around 1% of the UK population. It's slightly more common in women than men, but there's no question that early and intensive treatment is needed in order to reduce the risk of significant morbidities that are associated with it. Now, the peak age of onset in the UK appears to be between the ages of 30 to 50, although any age can be affected. Now, if it's left untreated or treated suboptimally, it can significantly impact on the quality of life, including employment, and it can also increase the likelihood of joint replacement surgery, as well as increasing overall mortality risk. Furthermore, I find the diagnosis is typically a clinical one, and investigations really provide prognostic rather than diagnostic information, but I'll touch on that as well. So let's look at the causes of rheumatoid first. The bottom line is we're not exactly clear what causes rheumatoid, but it is thought that there's a strong link to genetic susceptibility as well as some environmental factors. Now, it is relevant that the human leukocyte antigens HLA-DR4 and DR1 are more common in patients with rheumatoid, particularly in people with severe disease. And these HLA alleles are involved in coding a shared amino acid sequence which may well be involved in the development of rheumatoid. Surprisingly, smoking appears to be an important risk factor, and other possible environmental triggers seem to be diabetes, obesity, and the presence of rheumatoid factor or anti-citrulline protein antibodies in the blood. Now, for many years, a theory has been postulated that infection may be a link to rheumatoid, but as of yet, no particular organism has been identified. And again, for reasons we're not entirely clear about, the onset of rheumatoid does appear to be more common in the winter months than the summer ones. As we all know, the clinical presentation is usually relatively standard, but there are variations from patient to patient, and most present between the ages of 40 and 70 for the first time. Narrowing that down, 40 to 60 is perhaps even more common. But, interestingly, there is some evidence now that the first 3 months of the disease is immunologically distinct from later in the disease. And so early diagnosis and treatment undoubtedly beneficially affects long-term outcomes. So as we all know, patients typically present with a history of bilateral pain that's symmetrical with swelling of the small joints of hands and feet that they've typically been experiencing for several weeks. They may often have associated morning joint stiffness too, sometimes with joint redness and reduced function. Now, on occasion, you may also see rheumatoid nodules on the extensor surfaces of tendons, but I do find that these are uncommon on initial presentation. They are usually later findings, and over time, more joints become affected with increasing amounts of deformity, handicap, and unfortunately disability. If you see patients with advanced rheumatoid, you may see swan neck deformities, where there's distal interphalangeal hyperflexion with proximal interphalangeal hyperextension. So there's dip hyperflexion and pip hyperextension as a swan neck, and that's due to ligament and joint damage. And you can also get Boutonniere's deformity in advanced RA, where there's pip flexion with dip hyperextension. However, compared to 30 years ago or so, these deformities are much less due to treatment with disease-modifying anti-rheumatic drugs, DMARDs, at an early stage. If you're really unlucky, you may also get dislocation of the fingers or ulnar deviation due to inflammation of the metacarpophalangeal joints, and more severe disease may also present with other organs being involved. And I'm thinking of things like eye inflammation, heart inflammation, and interstitial lung disease here. Don't also forget a rarer form of inflammatory arthritis that we call palindromic rheumatism. And in this condition, there are attacks of the joint swelling and the pain that's similar to rheumatoid, but unlike rheumatoid, between these episodes, the joints actually return to normal. However, patients with palindromic rheumatism are more prone to developing rheumatoid arthritis later in their lives. So if we look at investigating and referring patients with rheumatoid, well, the diagnosis is essentially one made on clinical grounds from the history and the physical findings. But once a clinical diagnosis has been made, several laboratory tests can help to determine the prognosis or even confirm the diagnosis if required. So blood tests typically ordered by us include things like inflammatory markers, ESR or CRP levels, and these are usually done because they often reflect the degree of rheumatoid inflammation present at that time. But don't forget that up to 40% of patients with rheumatoid may have normal inflammatory marker levels. A full blood count is useful, and this often shows a normochromic normocytic anemia, and about 2/3 of patients with rheumatoid have a positive rheumatoid factor. However, this isn't required for the diagnosis to be made, but I find it is helpful because the higher the values, the worse the prognosis usually, and the greater the need for aggressive treatment. Now, if you've got rheumatoid negative patients, but you're convinced that they have rheumatoid arthritis, then another prognostic marker is known as anti-CCP, anticyclic citrullinated peptide antibody, and this is found in 2/3 of patients with rheumatoid and can be useful as a little investigation there. As can anti-nuclear antibody tests. These are positive in around 1/3 of rheumatoid patients, but don't forget that conditions such as SLE can also trigger them to become positive. And in general, around 10% of the population may also have these as weekly positive test results. What about imaging? Well, imaging tests aren't critical, but I do find that baseline X-rays of the hands and feet is helpful, not only to confirm the diagnosis and determine the disease severity, but also for longer-term monitoring, just to assess any progression of joint destruction. And patients with rheumatoid and erosions seen on baseline X-rays are at risk of severe disease. Ultrasound is often considered and indeed can detect synovitis of the wrist and fingers at initial presentation, and may also be helpful in diagnosing early seronegative rheumatoid. But current UK guidelines don't recommend ultrasound for the routine monitoring of disease activity in adults with rheumatoid. Now, NICE recommend that the early involvement of secondary care is vital in our rheumatoid patients, both in establishing the diagnosis and in starting DMARDs as soon as possible. So a specialist opinion should be sought for any adult with a persistent synovitis of unknown cause, particularly if more than one joint is affected, or the small joints of the hands and the feet are affected, or there's been a delay of more than 3 months between the onset of symptoms and the first consultation. Now, because rheumatoid is a significant cause of mortality and morbidity, and because treatment delays significantly contribute to both, then early and aggressive treatment with conventional synthetic disease-modifying anti-rheumatic drugs, sometimes with a biological agent or a targeted synthetic DMARD, is recommended. It's also suggested that the patient's hepatitis B and C status, their purified protein derivative, PPD, full blood count and LFTs should be checked before starting treatment, and their full blood count and liver function tests regularly monitored during treatment. Now, if you've got a patient with low-level disease at presentation, then these usually started on a single conventional synthetic DMARD. And NICE recommend first-line hydroxychloroquine here for patients with low disease activity over other DMARDs, simply because it's better tolerated and has a more favourable risk profile in patients with rheumatoid. But sulfasalazine, methotrexate, or leflunomide can also be started. Now, full blood count and LFTs need to be checked before starting sulfasalazine or hydroxychloroquine, and this should also be monitored every 4 to 8 weeks from the start of treatment. When the patient's on a stable dose, then monitoring can be taken down to every 3 to 4 months. Steroids, and I'm thinking of things like prednisolone here, may be used short-term for symptom control in patients with early disease, but should always be stopped as quickly as clinically possible in order to reduce the risk of longer-term side effects such as bone thinning. And non-steroidal anti-inflammatory drugs can also be used in patients with early disease for symptom control, but again given at the lowest effective dose for the shortest possible time, along with a proton pump inhibitor for gastric protection. Now, if you've got a patient with more moderate to severe rheumatoid at presentation, I'm thinking of things such as evidence of erosive joint destruction on X-ray here, then we need more aggressive treatment. And methotrexate monotherapy is the usual initial treatment of choice in these patients. However, if methotrexate can't be used, then alternatives include leflunomide, hydroxychloroquine, or sulfasalazine. But if your patient doesn't respond to methotrexate or has a partial response, then a specialist may suggest adding a biological agent to methotrexate, taking into account pertinent risk factors. And there are a number of these. So I'm not going to go through these in any great detail, but examples include tumor necrosis factor inhibitors, things like infliximab and golimumab, for example. There's also anti-interleukin-1 therapy, anakinra. You can use T-cell co-stimulator modulator treatment, abatacept, anti-CD20 therapy such as rituximab, or anti-interleukin-6 receptor therapy, tocilizumab. But all of these are obviously specialist-initiated. Now, what about the patient with rheumatoid who's pregnant or planning to become pregnant? Well, in those cases, corticosteroids such as prednisolone are viewed as the safest option, although both sulfasalazine and hydroxychloroquine can be used by a specialist with experience of treating pregnant women with rheumatoid if steroids aren't an option. In general, biological agents and JAK inhibitors are not recommended in pregnancy due to a current lack of safety data. But in general, rheumatoid symptoms typically diminish during pregnancy. Prognosis is vital when we're looking at our rheumatoid patients, but if we treat our rheumatoid patients aggressively and early in the course of their disease, they typically have a good prognosis, with most patients achieving good disease control long term, although flares of the disease are common even in patients who are well controlled with DMARDs. Unfortunately, delaying treatment initiation or leaving rheumatoid untreated can lead to patients becoming disabled within a decade. An untreated rheumatoid is also associated with increased premature mortality, most commonly from coronary artery disease. And a slightly chilling statistic, unfortunately, is around 1 in 3 people with rheumatoid have to stop work because of its impact within 2 years of their disease onset, and this number unfortunately increases over time. Finally, patients who are taking biological agents and who are in remission or who have low disease activity are at risk of their disease progressing again if these are discontinued. So thank you for listening for that overview of this enormous topic of rheumatoid arthritis, but I do hope you found it helpful and may have refreshed some of the things you may have forgotten about what we should be doing with our rheumatoid patients. But do have a look at the extensive show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following this podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our many virtual GP Notebook study groups and to download free shortcuts to help improve the lives of all of our patients in primary care. But as always, thank you for listening, and until the next time, goodbye.